That time she was very young actually, almost
Now
15 to 20
also.
years back. Even now she is very young. I don't think she's aging. Only those who are doing obstetrics are aging, I think. So, welcome to Kasoga, Nutan, and I saw the topic you're speaking also. It sounds very novel, and I'm sure that it will be of great interest to our Kasoga members. And I think none other than Rupesh could have been an expert. So, compliments to you, Prabha, for inviting Rupesh as an expert. And happy learning to all Kasogians. And Nutan, we will look forward to more and more collaboration with you in future from Bangalore Society, from Kasoga, from Foxy. We will be very, very delighted to have more sessions with you, Nutan. Okay. So, hello.
Yes, ma'am.
Yeah. Okay. Okay. Over to
Thank you, ma'am.
you,
Thank you.
Prabha. Thank you
Thank you.
very
Yes,
much.
ma'am. I request Dr. Rajeshri Palladi madam to give a presidential address for this
Yeah,
webinar.
pranams everybody and good evening. It's so hearty to see the committee webinars going on very, very sincerely every week. I must welcome Dr. Nutan Jain and thank you for accepting the invitation on behalf of Kasoga. Sarvastri Hitaya Sarva Samaja Sukaya. This has been our logo for the tenure, and we have 12 committees in Kasoga. And to put it on record, today it's 4 months completed since I took over as president, and every week since then, without fail, we keep having lovely Zoom meetings and the interactions for scientific exchange, and dutifully and deliberately and how beautifully I must thank my committee chairpersons for doing and conducting such excellent webinars, because knowledge sharing is never ending, and in fact to get the turn for the committee for the next term will be another 4 months of waiting, because 12 committees weekly, only 4 webinars in a month. But it's been a very, very joyful tenure for me with the committee chairs taking on the work so well. And I think in Kasoga, this is the first time on record that every week we are having a webinar without fail from the committees. So all the committees are working wonderfully, and I'm so grateful that this topic chosen for today's learning is an endless process, and any amount of learning and enhancing is very, very interactive all the time. So I have 2 chairs now, committee chairs, Dr. Rupesh and Dr. Prabha. And Rupesh himself has done such wonderful programs of screening the predictors and all last time. Excellent speakers were brought in then also, and the top notch are going on record, and we are going on record on the YouTube as well. So those viewers who fail to log in today can always log in into the YouTube and have a learning. So welcome to this wonderful learning evening, and thank you for accepting. And I welcome all the delegates and all the participants here to be a part of this wonderful program every week. Thank you so much, and thanks, Prabha. It's
Thank you, ma'am.
over to you. And
Yeah, ma'am.
I must say that, we don't want to miss any speaker according to the time schedule. So always we adjust, although it is 8 o'clock slot, but whenever the speaker or the faculty wants the time slot, then we are always open for any kind of adjustments, because we don't want to miss the opportunity of learning from anyone. Over to you, Dr. Prabha.
Yeah, thank you, ma'am. I think Shrisha Dipali had joined. Yeah, she was busy. So we will proceed further, madam, with your talk, Dr. Nutan, madam. I would like to give a short introduction of Dr. Nutan, ma'am. Arun, please, just this thing, no? Yeah, so first I would like to introduce our expert, the Dr. Rupeshan, none other than he's a endoscopy committee. Sorry, always it comes as endoscopy committee. It is a oncology committee of Kasoga, and he is a senior consultant and gynecological oncosurgeon, peritoneal oncology specialist. Actually, he has done much of work in his ORN, CA, and its peritoneal deposits, and he has multiple international publications and research also on that. And gynae laparoscopic and robotic surgeon practicing in Bangalore. And he is a visiting consultant in so many hospitals, mainly Sparsh Hospital, Infant and Motherhood Hospital, and Manipal Hospital at Mysore. He had a number of awards in specially in gynecological oncology works, and he has recently won a prestigious European School of Peritoneal Surface Oncology Fellowship with Hamburg universities, and invited as a national and international speaker also. Welcome you, sir, as a today's expert. And
thank you.
And before Dr. Rupesh, I would like to welcome Dr. Mala Raj. I think I see her on the screen here. Dr. Mala.
okay.
Yes, over to you, Dr. Rupesh.
Yeah. So, Dr. Rupesh, sir.
Yeah, thank you. Thank you so
Yeah.
much for the kind introduction.
Yes.
It's an honor, especially we have been seeing Madam's name in so many books. You know, when we were, in fact, PGs also, and of course, way back in 2007 I finished. But I have seen Dr. Nutan Jain as a name in so many books. So today, it's an honor to be here listening to Madam, and especially
Hello.
President Dr. Rajshri Madam. Hello.
Yeah,
Yeah,
yeah, yeah.
thank
Yeah.
you so much, Dr. Rajshri Madam. Yeah, Dr. Rajshri Madam, dynamic president, for always instilling the confidence in us to go, more and more aggressive in terms of all the academic events. As well as I can't thank much Dr. Prabha Desai Madam, because despite being such a busy person, she's always smiling, she's always calm, and she's always open to learning as well as teaching. So she runs a fantastic course. Thank you, everybody. And of course, Shobha Gudi Madam, for all those kind words. I would like to introduce Dr. Nutan Jain. She's the director of Vardhaman Fertility and Endoscopy Center, Muzaffarnagar, India. She was inducted as an international advisory board by Society of Laparoscopic and Robotic Surgeons, USA. And she has been a part of live telesurgery relays of laparoscopic surgery to AAGL at the 46th Annual Global Congress in Washington, D.C., USA. That makes us Indians very proud today to be listening to her. She was also nominated for AAGL, the American Society, as well as a board of director in 2009 and 2019. She represented the Asia Pacific region then. She has also received the prestigious award, the Harith Menon Hassan Award, for the best presentation promoting education or training for research work on role of ICG in SLS MIS 2024 in Florida, USA. She's received the Best Innovation Award, the first prize, in fact, at ASICON 2021 by the Association of Surgeons of India for pioneering work on the Jane point technique. Madam, we would like to know more about it. I'm sure you would be elaborating that in your talk. She has also introduced a novel laparoscopic entry port, the Jane point, and released also a book on the Jane point, which sounds very interesting. She has been author of 9 internationally acclaimed laparoscopic surgery textbooks, translated into Spanish and Chinese. In fact, I keep, when I was in Spain, I used to see such wonderful laparoscopic surgeons. I've seen some great Chinese laparoscopic surgeons as well, but when Madam's book has been translated to their languages, that is nothing less than immense pride for us. And she's recently launched the global reference book, Complex Total Laparoscopic Hysterectomy, with newer approaches in bladder dissection. Madam, we can't wait to hear you. There's so many. These are only just a gist of Madam's achievements. I'm sure there are many, many more, which is definitely more than that. We will be listening to Madam's talk now. Over to you, Madam. Thank you so much for being here.
Yeah, first of all, thank you so much for that elaborate and kind introduction. And happy to know that my books do serve the purpose which I always carry in my heart, and that is to propagate and share knowledge, whatever I have.
Thank you, madam.
First of all, now I would like to really thank my loving friend Dr. Prabha Desai, who invited me over. And it's a great pleasure to be in the KSOG, you call it, the endoscopy committee meeting. And Dr. Rajshri Palladi gave a very nice introduction about the activities and the various committees. So wonderful. And Dr. Shobha Budi, I have met her several times and she remembers me only from Rage. But I think we used to meet earlier at Dr. Rajan's conferences also. And Dr. Sirisha, the secretary of the endoscopy committee. So lovely to see all of you. And I think I should start with my talk.
Yes, ma'am.
So,
Can you just share the screen?
yeah, I will start.
Yes, ma'am.
We are just doing it.
Yes, ma'am.
It's like ICG is just like, a green revolution, a green pathway added to better your surgeries and to give them more precision. That's fine. Yeah. Next slide. Are you able to see my screen now?
Yes, ma'am.
Yeah. So, welcome and greetings from our center. That's Vardhaman Hospital. Muzaffarnagar is a very small city, but we were able to bring up this center of repute. This is the operating room and our operating team. And we have 5 endoscopy suites just connected to each other. So, we are able to carry out some quality work in a shorter span of time. So, the role of ICG in the in laparoscopy in the emerging structure defining technologies in gynecological surgery. So what we gynecologists started knowing more was the application in the urethra for severe endometriosis cases. But today I shall take you over to many more applications which we have learned over the years. So we can simply say it from anatomy mapping to perfusion preservation, and also we will highlight the role of sentinel node sampling in oncology applications. So if we just see, there are 5 things. First is anatomy mapping, highlighting the structures and the lymphatic pathways when anatomy is distorted by adhesions, like endometriosis or very severe PID. Perfusion assessment just after or for organ preserving surgeries or after resection reanastomosis in endometriosis. It improves the surgical precision, and whenever we have the fertility preserving intent of the ovaries or of whatever organs is we are dealing with, it helps. So what is ICG, the wonder drug? This is a tricarbocyanine dye. The molecular weight is 751. It starts its fluorescence around at 830 nanometers. So, and it comes as a very simple lyophilized powder, a vial, and it has been approved by FDA since 1959. So, very simple how it works. Wherever we inject ICG, it can be IV or in the organ specific. Then it rapidly binds to the plasma lipoproteins in the circulating blood or in the structure, and it emits green fluorescence which around more than 800 nanometers, which is captured by the camera systems which are specific, and then we get the real-time filtered. So it is water-soluble, non-ionic, and has a rapid hepatic clearance, and also appearance is within few minutes. So anatomy mapping, as I said, mostly gynecologists, we just started with the urethral visualization, and we are ever expanding our horizon or where to reach. The goal is safer dissection and not blind reliance on fluorescence. Perfusion awareness, as we said, and expose the anatomy first. Use ICG to confirm or augment what we see, maintain the meticulous dissection, and respect the tissue planes. So whenever we combine these surgical principles, our safety and our precision definitely improves. So just see in this entire maze, the appearance of this green pathway, it can act as a green pathway. So gradually we keep moving along with it, and now we can just easily transect the tissue which is binding over there, and we can preserve the nerves and the surrounding structures once we see. So now these are the newer applications which we have started using in the reconstructive procedures for prolapse, vaginal cuff, perfusion, and recently we did a case of vaginoplasty in an XY female. She was phenotypically female, but it was XY. So we will just summarize. So more established is Dr. Rupesh field, sentinel node mapping in gynecological oncology. a high detection rate across cervical, endometrial, and vulvar cancer. And maybe ureteral visualization helps them in the radical hysterectomies also. So expanding adjunct is perfusion, emerging and limited are ovarian torsion, hyaluronic and vaginal reconstruction. So all this, and there are some limitations which will improve with AI, the depth, penetration, background fluorescence. We have found out our own ways to decrease the background fluorescence and the dosing and everything. So we are presently taking a part in an international Delphi trial of how much to use and when does it appear. So all that. So there's the entire Society of Fluorescence, International Society of Fluorescence Guided Surgery. So just take you in a minute about the history of surgical visualization of ureters by adjuncts placed in the ureters. So as we have already talked about it, so now it has been expanded to robotic and other types of surgeries. So we way back in 1913 somewhere, or we got these lighted ureteral stents which were by the name of Iris Urokits by Stryker, and they used to be 22,000. So, and they used to illuminate just like this. This was the continuous method, and that time the endometriosis surgeries used to be benefited by this. Not fluorescent, this was the excitation of some lighted. Then they were in two modes, continuous or the pulsatile. So this we used when we did the live surgery relay, because this was a massive prolapse and we had put in the ureters, the lighted stents in the ureters, and we were able to give a good complete repair. So looking into all the applications, I feel that it is like a green lantern which highlights the pathway of where to go ahead with the exact surgical play. So it is non-toxic, non-ionizing, real-time visualization, and it has the deep tissue penetration. And obviously, this way it enhances the surgical safety. So the progression of FGS over the years. So first, as I showed you, were the Euro kits. Then second came the first generation of fluorescence, the NIR mode. So in this NIR mode, we used to turn it off, turn it on whenever we needed. But the drawback here was that we used to use the vessels, the other structures. So this was a little drawback, but since it was the first thing, we used to enjoy working on this also. And this used to be the picture otherwise, and this was the NIR mode. Then came the overlay mode. This was a game changer. That because in the real-time fluorescence, you were having your normal laparoscopic picture, green signal on natural color anatomy, no switching to the dark mode. So this was it. So with this, we acquired the 1688 system, and that is the room and the team. Then came further enhancement, and that is the 1788. And this has multiple fluorescence visualization modes. So what they are, this is called as the color segmented fluorescence. And it helps. Like supposing we see here, the orange color is much more perfused area, and the blue or the green are the lesser perfused areas. So if you switch it on, you can come to know. So this allows the surgeon to quickly identify which is the well perfused tissue, which is moderately, and so on and so forth. This is the ischemic. So if we see any area which is ischemic, supposing we see it around the ureter, then we can put the stent, or it is used for your bowel dissection venous thrombosis at the last step. So red and orange are with adequate or excellent perfusion. Green and blue are borderline or poor perfusion. So just to show you, so this is how we use it. So this is not a perfect case for it, but this was the case of peritoneal endometriosis, but we were doing it in that mode. So applications in gynae MIS are ample. As we have already said, SLNs and vaginal curve vascularity and clear visualization of the vascular supply. So we took an early lead, and by July 2024, we published our first series worldwide in the AGL journal. And first section which we will talk about is the ureteric visualization. I think for gynecologists, ureter is the number one enemy. So let us take the first enemy first. So as I said, it has a short plasma life. approximately 3 to 8 minutes, and clinical role is visualization like this. So the surgical procedure is commenced and the ureters are visualized due to fluorescence and fluorescence immediately. So what is the technique of injection? So before the technique, let us have a little fight. Who will do it? The gynecologist or the urologist? I would say, since the word is urogyne, so we are 50% by the terminology also responsible for doing the urogyne procedures. And plus, I will show you in the next. So I will encourage my gynecologist friends to do a week of rotation with the urologist and learn the nuances of doing the catheterization, or at times even stenting. So how to reconstitute your ICG? So first of all, it comes as a 25 mg vial and that is diluted in 10 ml of distilled water. We take 2 ml of this ICG injection and redilute in 10 ml of distilled water, giving it a 0.25 per ml constant dilution. So then 5 ml is taken and injected on each side. But we have revised, as we said, that all of us are learning, and we found that 2 ml reconstitution was giving a much more needed fluorescence. So now we reduced it to 1 ml ICG, and this was what we talked in a paper in US in the SLS, and everybody, when they saw our images, they said really it is showing so well. So the lower dose causes controlled fluorescence, clearer anatomy, and no background green color. So I'll just show you in a small vial because after every talk, everybody wants to know how to reconstitute. So this is the light hydrophilic vial and it is just 1200. And those Euro kits used to be 2200. So, and then this is the filter. So first we instill this and instill another 10 cc in this. And then 5 ml from this for the each side of the ureter. And if it is to be given IV, it is 0.25 milligram per kilogram body weight. So how to use the technique of administration. So we need a Teremo wire. This is a routine Bitoki hysteroscope. And these two things are important. So as we do a tubal cannulation, we can simply first we introduce the Teremo guide where it is very important that this ureteric catheter be only railroaded over it and do not go like earlier we were told that to go up to the third mark or this and that. Now we find that going only just about 4-5 centimeters and then injecting the dye serves the purpose of illuminating the catheters, the ureters. So this is the way we do it. So now why am I having to go like this? Because we are using a hysteroscope which is 30 degree and the cystoscope telescope is 70 degree. So either we buy a telescope or we can use a routine hysteroscope like this. So the routes are IV. So 25 mg is diluted again 3 ml bolus. And this is intraureteric as I showed you. Intravaginal, we will show you later on how to do it in the rectovaginal space. So many experts, so I feel that there's a lot of, stigma amongst the super specialist surgeons that no, we don't need it. So this used to be, Shobha may be from that era, that when we started doing hysterectomy, LAVH, so the vaginal experts used to say, no, we can do this vaginally. There's no need of doing it laparoscopically. So the same thing, there's a little antagonist that we do not need it, but we are from the same era of expertise. So it reduces a lot of stress, decreases operating time, blood loss, and a decreased rate of complications. So just this video, if you see, that where's the uterus, where the ovaries, nothing is seen. So redo surgeries can give you any challenge anytime. So at the beginning of the procedure, when everything is a frozen pelvis, just this green hint gives you an opportunity to identify the medial pararectal space. And here this is on the right side. So this is only the round ligament which I could see in the beginning. So this is an earlier video. You can see the green background over there. So here on the left side, when I'm able to see the ureters, for me, from here to work on, and one ovary has been lifted up and tagging the ureters, lateralizing them, and also taking care of the hypogastric nerve. So now this is the rectovaginal space. Till here, we are able to lateralize the ureter and dissect the rectum out. So there's complete clearance in the rectovaginal spaces achieved. So that's the final picture of that horrible case. So it has been seen, validated by the surgery task load index, that routine integration significantly lowers the surgeon workload and mental fatigue during complex DIV cases. So identification of ureters during difficult lab surgery, another case. So if you see, so all our cases in India, I will just tell you that so this is over the sacral promontory. We first opened up the pre-rectal space, the retrorectal space, then going along the Walde's fascia, opening up a large segment of the middle pararectal space, and now coming onto the right side, opening up, the ureters are seen. There's no extra step done to look for the ureters. So you save a lot of time. And if you see, this is the vaginal sponge. So this is the rectum and that is the vagina. So this can also help you to gain access easily. Not easily, you need to know all the affect your rectum, but definitely color coding and getting trained at places where these things are done routinely can give you a lot of help. So that's the final picture. So now a big chunk of the rectovaginal nodule has been found, it has been dissected out, and see that this space is clear. So the patient will be freed of a dyspareunia and dyschezia. So another case, it's a 38-year-old female and long married life. All these symptoms are dysmenorrhea, dyspareunia, and dyschezia. So a retroverted globular uterus. And if we see again, everything is totally jammed up. So we start our incision along the white line of Todd. And obviously in redo cases, as Dr. Rupesh was saying, we make the entry to the gem point. But with all this, if we are able to lateralize the ureter and see it in the very beginning of the surgery, and the another structure to be very careful about is the hypogastric nerve. So in the later videos, you'll see that we start, now if you see, this is the external iliac vein, and many times we are starting even higher up, and we see the common iliac vein. So at the sacral promontory, we just open up the retrorectal space and lift up the rectum like a canopy. So we call it the first rectal canopy this way. And it is very easy. Once we get into this, the dissection goes along the Walde's fascia, and the dissection for us is only color coded between the yellow of the rectal mesorectal fat and the white cotton candy tissue of the middle pararectal space. So now this is the second rectal canopy. We get these two, and after this, it's such an easy thing. So we have made it like mathematics. 2 plus 2 make 4. You first start at the sacral promontory, then go and open up the middle pararectal space, then the rectovaginal septum, bring both of them from both the sides, converge them, and then the rectum, the nodule is removed. I put too many videos. Prabha, is it okay to continue with some?
Yes, ma'am. Yes, ma'am.
I remember you said that put more videos so that.
Yeah.
So
You can, ma'am.
see, all these cases are for complex grade 4 endometriosis. Totally. In India, we see a very quick emergence of very severe disease, fibrotic disease. So we have started a survey at a center in which we are asking the patients what age they start. I'm kind of connecting it to the bandwidth and the extensive use of the mobile phone. So we are trying to find out the severity of the disease and the hours of extensive use of the mobile phone. So we have just collected about 10 patients. This has been done just 2 days before. So maybe as we get some encouraging results directly incriminating the increased bandwidth. So again, if you see working at the sacral promontory, and this is the common iliac or the external iliac vein. But the only thing here is to make a horizontal incision and be very careful that the vein could be right over there. So just see in this case, the ureter is almost totally adherent over to the rectum. So much medialized ureter. So these are the cases where really in the redo surgeries. And even nowadays, I see that even the first surgery, the patients are having very extensive fibrosis and adhesions. So I think this was only to show the medialized ureter. So now the second rule, the most often performed surgery by a gynecologist is TLH, and we have found some encouraging results in complex TLH. So we will just show you this case. It is a previous 2 cesarean sections, and since the advent of the single layer closure, we see very extensive adhesions of the bladder. So that is why it prompted us to have a book totally on bladder dissection. And if you see here, now the rim of the manipulator cup has been tagged with ICG. And now it becomes easier to carry on the dissection between the bladder and the adhesions over this manipulator cup. Start. So here again, we popularize the term called the bladder canopy. So the bladder is totally lifted up and we try to reach the cotton candy space. And here, so there were adhesions are very extremely dense. So you're trying, and for this technique, we first go over to the uterine artery. And we try to do as the oncology practice, we take the posterior approach and coagulate the uterine arteries first, and then the bladder is dissected. And if you see here, the entire cup is now visible, and we can then carry on the colpotomy. And here we can clearly see that the bladder has been totally mobilized and the colpotomy completed and the suturing done. So these are the emerging roles as we keep on doing almost all 6 days of the week. We are using ICG. So this was a case of a very severe parametrial endometriosis. So here again every time. So you will see that the left pelvic brim is the key to unlock the pelvis. So the moment you see here, the ureter in the left common iliac vein, then go over. So if you just see these, you will have a very clear understanding how to go about. And we have made such very clear steps. So sacrum, yeah, this is we call it the rectal canopy. We are using a rectal probe. So here we cannot avoid going very close to the ureter because the perimetrium was very extensively involved. So this is the rectum, which we, by the manual pressure, by putting a rectal probe. So today, as I was going through, I saw that one of the papers wherein the rectal probe was also tagged with ICG. So let's see. So whenever we say that we are going to take a webinar or something, it's not that we are sharing, we are learning to put up good slides, the latest researches, everything. So we do a lot of paperwork and thorough research, and we answer, and then now when the question answers come up, I will learn still more from my inquisitive audience and the experts. So now this is the rectum totally adherent over there. And you see that I am very simply using harmonic only and going into the retrorectal space over here, the rectovaginal space, sorry. And there was a lot of tissue over here. So we are always very careful about the hypogastric nerve, and we are, whatever the nodular part, only that is removed, and we take extreme care. So once you have the most important structure, and here in such cases, when you are doing the uterine artery, at that time also having to know where the ureter becomes very important. So this was a case done just 3 days back, I think, and she had previous 4 C-sections and a totally ventrifid features. And we were not even able to pass a dilator. It was so hard. So first we started doing the adnexa, and if you see now I'm showing you the posterior approach. So we already, in any complex cases, we tag the ureters, and now I've taken up the uterine arteries, but the adhesions were really tough. We tried going from the other side, and as you see, the anterior abdominal wall, the bladder, and the uterus adhesion, they were all making a complex jumble. So we had to put in a uterine manipulator, and then this manipulator's posterior rim showed us the exact point from where now this is the uterine artery which has been tackled first before the bladder. So this is known as a posterior approach. So from here on, we reach the psychovaginal space, and we always look for the cotton candy space. You see here. So the moment you do the uterine artery, once the uterine artery has been taken care of, the ureters move laterally and downward. So this is what we call as a cotton candy space. And though the uterus and everything is still adherent on the top, we see that we are able to remove the bladder adhesions. And here, by doing, here I use the monopolar hook also because it was taking too long with the harmony. So I felt that in this case, also using the ICG in TLH also for tough bladder discharges did make a difference. So the colpotomy, and if you see that the bladder was densely adherent over there. I think it is all finished. Let's go to the another video. So we see that they have looked at the perfusion also, that it is better with ultrasonic versus colpotomy with monopole. So this was the textbook I just mentioned. So role of ICG in parametrial endometriosis, just a very short clip. So though we have shown it enough, but if can decide it's very small. So initially all cases might look very simple, but as you go deep, you open up the retroperitoneum, then you see that that's a ureter. There's a little blood supply also over there. So we need to preserve this blood supply and take care of the surrounding parametrium. And these patients are the ones, here this, I want to give a small message about the medical therapy which is given to patients for long enough, because endometriosis is a very important cause of silent kidney failure. And it's not unusual to see about 1 or 2 cases per month who have been treated for medical therapy for very long, and then they'll end up into hydronephrosis and loss of kidney function. So this was the award which I was not expecting even. As the last time I, even the last date had gone beyond, but there were a lot of appreciation for the work on ICG. So I will just show you one case so that all the audience who are a little fond of medical treatment. So this was a hydronephrotic left kidney, and that patient had come from Jammu Kashmir, and the urologist had already put in a stent, and then she came to us for the required surgery. So we had two options. Either you go for a uretary reimplantation, but we first tried to have a organ preserving surgery. So again, in the same manner, we have started from the pelvic brim, and you will just see the grossly dilated ureter. So we are very careful in this case. Just see the grossly hydrodilated ureter. Our technique remains the same, starting very high up, going to the hypogastric nerves and clearing up. So now you see this ureter, which is adherent to the back surface of the uterus to the ovary, and the patient had given a consent for removal of her left adnexa because whatever her reason was, she was around 40 and she has completed her childbearing. They just wanted all of the disease to be cleared up. So this is the rectovaginal space we entered, and preserving the hypogastric nerve is very important. And in the coming few slides, we will see how we can also do a better visualization of the hypogastric nerve by using the ICG. So that's a newer application for me also. So firstly, the adnexa was removed, and now this will be put in an endo bag and removed. Now this is the area where the ureter is kinked. So now putting on the ICG, you just see that to remove the entire encircling ring, we had to really thin out the, that's a compulsion. In parametrial disease, it is always said either you leave some disease or you have to put in a stent to preserve the vasculature and the viability of the ureter. So now all this was done, and this patient just after 6 months of her surgery, the urologist from there and the patient, they both spoke to me. Now the stent has been removed, the ultrasound and kidney, patient is doing well. So this was a message that rather than empirically treating our patient, they should be subjected more to more dynamic surgery. I think we can. So now just one more indication we found that when we are doing a rectal check, we can inject some ICG into the that fluid which is injected in the rectum. And now you see that after such cases, rectal check is always mandatory, but having it and the same ICG which was reconstituted for that. So now this was not only for expert, I would say the challenge for expert is different and a challenge for a novice is absolutely different. So peritoneal endometriosis, so it is good for novice endoscopic surgeons to enhance the ureteric safety even in simpler cases. So you're just out of college and you want to do endometriosis, and I say that in times to come, all camera systems will have ICG enabled. So you will always have it with you. So occult lesion detection, this can also be done by intravenous NIR. So earlier we used to say that these are subtle lesions we cannot see, but now you can easily see them. So that is just the tip of the iceberg. I'll just show a video of a complete peritonectomy. So here we see that there's the involvement of the right uterosacral also. So one thing, Prabha, I have started seeing that the disease in India has started coming more on the right side also. The preponderance
But
on the left side is really going away. And I attribute it to the placement of the mobile phone on the right pocket of the tight jeans. So as I
okay,
said, we have started a survey and it has all the questions: where you are keeping your mobile phone, how far you are keeping it while sleeping, and what are the hours. And people have said that before going to bed, at least 2 to 4 hours also. So
okay,
that's spoiling the lifestyle also and everything. So this is, as some people call it, the butterfly peritonectomy. And in case, in such, though it is not very deep, but it is involving all the structures. So if you are able to put in your ICG mode, you can stabilize. Now just see here, it was not expected, and suddenly the ureter had come up. So whenever, even if you are a little negligent, you can always be, you have an adjunct. So why we take a walking stick? At times when we need it for some extra support. So like this. So like this type of implant is right over the ureter. So as I said, for novice or for intermediate who are wanting to, because the quantum of endometriosis is so much, everybody is bound to do it now. So I tell my fellows every day that you people are going to have a much tougher job than we people. Because endometriosis every week I feel that it's growing really too fibroid. So that's a completed picture. You may call it the butterfly peritoneum also. So as I said, if we tag it, the visualization becomes 86% compared to 22. So the dissection of RB space, I think I've shown enough. We'll just see that it causes the vaginal denudation where it's sponge in the vagina. So I think all other videos have shown it. So some newer applications, preserving the ovarian perfusion. So just see that IV infusion can be given, and this can be a great help in adnexal torsion. After a large cystectomy, we can just inject ICG and see what ovary we are leaving behind. And there's also, I have not included that slide, it's getting too long. The antral follicle count was quite parallel to what the ICG perfusion was shown. So I'll just show you the preserving ovarian perfusion. है ना? So
Yes,
this was
ma'am.
the case we did, and we detested it like this. It was much better. And then we went again for a second look procedure after 6 weeks. So now at that time, if I had ICG, I would not have to undergo this second procedure. So anybody who thinks that it is only for ureter visualization, no. So patency, tubal patency. So real-time tubal patency, and I'll just show you how for myomectomies and all. So just see, now this patient has come as a corneal block. But we see the fallopian tube having the right tail over here. So you can easily make out that this is a case for tubal cannulation or not. For myomectomy, it does a very definite role. So this was a case where we had tagged the cavity green.
Endometrial.
Endometrial. So this patient, we had just opened it up a little. So we just sutured over it and the integrity became much better. Same is for adenomyomectomy. So again, this is an older video. And in this, you will see that we are removing the chunks of adenomyotic tissue. But now supposing if we had ICG tagged into the endometrium, or if we had the knowledge, we had ICG, but we did not have the knowledge that we can put it in the cavity. So here in adenomyomectomy, we can leave a 1 centimeter rim by the knowledge that the ICG can be visualized when we go very close to the endometrium. So I think it's a large chunk has been removed. So again, as one after the other we are removing. Now at this point, supposing we were able to see, we can be much more confident that we are leaving a good amount of myometrium and the integrity will be good. So this can be used. So pelvic floor, I've already said that many people, and we are doing a lot of this high uterosacral ligament plication where the ureter could be at risk. So if we have the facility, we can simply tag the ureters. So now I'll just show you a nerve sparing procedure. If you see that on both the sides, the nerve as we dissect already. So this video is only more to show how to preserve the nerve. So
Bye.
the parallel space.
Please mute. Hello.
Yes.
Please mute everybody. Arun.
Yes, madam,
Yeah.
done.
Please.
If you see, here is the hypogastric nerve. That's one. If all of you know, at the superior hypogastric plexus at the level of sacral promontory, it divides into right and left inferior hypogastric nerve. So that the inferior hypogastric nerve is the core basic supply. So you see the nerves on both the sides. So now, but we will have the liberty of using IV ICG and seeing the nerves more clearly. So this will be our future endeavor to work more on this. So this can be seen like this. So this was the benign gynecology and a little role about the ICG in sentinel node sampling. So, so what is sentinel? A soldier or guard whose job is to stand and watch. So this is the primary tumor, and if first goes to this basin, if this is negative, then no further thing needs to be done. So SLN mapping aims to identify and remove only the nodes which are important, like they are responsible, and it can avoid unnecessary lymphadenectomies. So this is what we all know. These are the various groups of lymph nodes, but we can tag them like this and then remove the targeted ones. So the direction for use is that we put at 2 points, 3 o'clock and 9 o'clock. The superficial is only up to 3 mm, and the deeper is that we take the small needle and we pierce it completely in. So earlier when we used to go to AGL, we heard about the hysteroscopic submucosal injection. Now I think it's totally standardized, only cervical injection. So we're just showing a little. On one side I'll show you. So this is a small insulin syringe we inject. And during the COVID, when patients were not able to go to dedicated centers, and the earlier endometrial cancers of which are not very advanced, or no myometrial, not much of myometrial invasion, we did a lot of these surgeries. So this is the application, and we should put the laparoscope right in to see the entire root of the nerves as they are getting stained. So this is the external iliac group, and just see how clearly it is seen. And we can, and one more need to be clear, that along with when we do the sentinel node, there is no need of uh, frozen section. So many people have carried this impression that sentinel node, if you do at a center that where there is no frozen section, so it is a good thing for average gynecologist who can do up to this dissection. They can carry on. I'll just show one more case. So that this is the typical approach for lymphadenectomy, the triangle between the round ligament and the isthmus. So this was an earlier case where we were doing with the only the NIR mode. So here also you can see very clearly, in fact better with the NIR image. But here only the thing is that you do not see the, but we see the vessel, it's a time. Like we used to enjoy the black and white TV, and later when the color TV came. So one word of caution here is that a person who is doing SLN needs to be more experienced with the, so cure and complete treatment. Hypothesis is that if for one node are negative for malignancy, the remaining regional lymph nodes will also be negative. So the NCCN guidelines, they endorse SLN mapping as BSGO, SGO, and all other national or international societies, they endorse it. And it's very important that we do the SLN lymph node, we should do the ultra staging. Whenever we send our samples to the lab, we always tell them, and some part of it, one slide is stained, and IHC studies are also done. So this is the ultra staging. So the sections are cut at 1 to 2 millimeters. So this is the logarithm. People in the onco section would be knowing better. So it reduces the operative time, blood loss, lower lymphedema risk, and it has almost become the standard of care in endometrial cancer. But again, I said any person who's taking up these surgeries should be good enough, if at all the need is to do a complete lymphadenectomy. Because if at all, even if it is negative and any node looks suspicious, we have to do it, or maybe a hemi-lymphadenectomy needs to be done. So what would be the complications to sum up my talk? So intraoperative complications across major systemic reviews, ICG administration consistently demonstrates a safety profile which is almost negligible intraoperative, and we have to already find out that the patient is not iodine reactive, sensitive. So based on the European Association of Endoscopic Surgery consensus, FGS surgery is rapidly shifting from optional adjunct to a foundational standard of care in the high-risk pelvic surgery. And for beginners, I would say for even medium-ray surgeries. So it has a broad utility, clinical impact to improve precision and safety. So this was a very lovely slide I always like. If you don't have to look up for the ureters, they simply show up. So it's a green revolution. Don't stay behind. Join the bandwagon. Earlier the better, and become a better surgeon with more. So this was maybe Dr. Rupesh was mentioning. He must have read the first volume, the first edition of this book. Now this is the third edition we came up, and definitely we have put on the cover because we can never forget ICG and so. Thank you so much once again, Prabha, and your Dr. Rajshri and Dr. Shobha, and we will be waiting to hear from your expert, Dr. Rupesh. Thank you so much.
Thank you, ma'am. Thank you for giving such a elaborative talk. Actually, it itself has cleared so many, doubts in who want to use now or who are using also for them. So, Dr. Rupesh, sir, the now next 10 minutes are for you.
To be very honest, it's always very nice, like a fresh breath of air, whenever you are like so stressed out. So in an entire day's practice of seeing busy patients and having that mental fatigue, when you get a beautiful talk, or especially with such wonderful videos demonstrating, and that's pure knowledge. So that is what we were able to have, like a feast from Nutan madam. Thank you so much for the fantastic wonderful deliberation. It was really nice. It was eye opening, especially for us. We keep doing so much of oncology work, especially being a peritoneal oncology specialist. For me, especially in ovarian cancers, especially in previous cases of endometriosis. Like, I mean, we see many cases of clear cell carcinomas or endometrioid
Yeah.
adenocarcinomas. So
Right.
again, there's always a challenge. I always used to keep thinking that most of the times, we end up like as closer to the mesoureter. The disease is very, very obvious there. And of course, from the onco perspective, for us, we are used to operate. We know the ureter. We don't generally. I hardly call a urologist, and I hardly use ICG. But yes, the point is, for an evolving gynecologist, and especially in today's practice with the wonderful systems of Stryker, of course there are many other companies like Olympus and Rubina from Karl Stores, but I personally, just like you madam, I'm also a huge fan of Stryker 1788. So I keep telling many gynecologists, if you are starting a hospital and if you want to invest in a laparoscope,
Yeah,
please,
good
that is the
camera.
best at this point of time. So after that advent, for any evolving gynecologist, I'm sure that your presentation today is an eye opener, because it tells how important at many junctures that we can keep using ICG. You listed out almost so many conditions, like even for an ovarian detorsion, we can see the vascularity. In
Yeah.
fact, look at the endometriotic spots. Also, we can see the through ICG. Of course, ureter. I think currently there's also one protocol for IV injection to visualize ureter also.
Yes.
Especially, yeah,
For the
there's
perfusion.
only for the perfusion aspect. And even for currently we also do a lot of rectal discoid resections. So sometimes when you do the rectal discoid resections and when you do the seromuscularis sutures, there also we can use ICG. And especially the vaginal reconstructive surgery is totally they are again amazing features there. And yeah, even I think I had noted one more thing, which is like especially when we do the rectal anastomosis, I mean resection anastomosis, also again the GI surgeon or even us who are doing, it's going to be great use. So ICG is like, as you said, having somebody guiding you through as a light is one of the very good suggestions. I mean, very good adjuncts for any gynecologist to learn things to do correctly. Because earlier days, I still remember 10 years before, like gynecologists, I mean, the senior gynecologists or obstetricians used to tell that if you have not injured a ureter or bladder, you're not a good surgeon. But I
Yes,
think
you have to do it in your lifetime.
We
yeah,
can't afford nowadays.
yeah, we
We
shouldn't,
can't.
we shouldn't. So I was like, I was always rebellious, and I was always telling my professor why I should endure. No, I will try to do without karke. Of course, I used to take a lot of time, during dissections, and was being criticized by the anesthesia team initial days, I should say. But then, yeah, with adjuncts like ICG, life becomes so easier, wherein there are different ways that we inject ICG for various things. I mean, the concentrations are different. Now there are clear-cut guidelines and how you do it. It's just that we should have the near-infrared assessment, enabled systems. So, which is something which is very important. I know that cost is a constraint in our country. In fact, the first thing what robotics, they tried to gain garner attention was because of we have a ICG enabled system. So that is how the robotics came. Actually, they only have the Firefly system, which is actually if you have to say the technical complexity, it is still less. I mean, it's rather less quality compared to the 1788 striker, because you mentioned about the CSF mode, which is very important.
Very
The color
important.
spectral fluoroscopy is something which is so beautiful. In fact, recently when I did endometrial CA, a young lady, 34-year-old lady, the moment I came out, I was using the CSF mode I had. I could see that in the overlay mode, there is a lot of confluence of the entire lymphatic channels which were there, wherein I was like doubting, should I remove more number of nodes here to ensure that I have removed all the SLNs. So, but then when I use the CSF mode, I could see that the intensity of the few nodes, the real hot nodes, what we call the hot nodes, they can be beautifully, found out by the CSF mode. But of course, I was in I was with the discussion with the striker guys. I told them I have proposed them a study as to kind of pathological correlation also. But I'm sure that that is a beautiful modality that the newer systems possess. And with this, not just here, I'm sure that further down we have multiple other applications. In fact, there is a dye called a Cytolux that we use, which is available in the US. We still do not have the license in India. So we use that for peritoneal cancer surgeries. So that is also something, wherein the ICG tagged folate receptor dye, that is. So because many of the ovarian cancers express folate receptor alpha. So that is what we use. We are starting to use as an investigational thing in many of the places, wherein we know which part of the peritoneum to be removed. Of course, I do a total parietal peritonectomy. I remove everything, we take around 12-15 hours surgery and we do that. But again, with the advent of ICG, dyes like ICG, it becomes so beautiful that it does a focused and a relevant surgery. So I think madam's elaboration, I think you did not leave any condition, madam. You have told the only thing which I remembered was, I read somewhere that even for a fibroid capsule, it can be injected before doing a myomectomy. I do not know that because I haven't seen any video. Maybe I should see sometime your video only. I mean to say, before a myomectomy also
It's
it can
just
be
the
injected.
beginning, I would say.
Yeah,
Like all the audience who would be people who will be listening to the recording later, and those who have access to it, every day they may come up with newer applications.
absolutely, madam. Absolutely.
And one point I was trying to make on Dr. Rupesh, when
Yeah.
you do your surgeries, the redo surgeries of ovarian cancer, at that time, you had said one time that you really want to know a little more about Gen Point, and we really forgot to
Oh
put it
yeah.
over
Actually,
here.
I just saw that in yours. I had come across, but I hadn't seen in detail about it. If you can show me that,
I'm sorry,
or
yeah.
show us.
So next time in any of my talk, I will put it up. So I will just tell you that you have to just remember two things. That when you are doing a cancer surgery, and Dr. T.S. Rao,
Yeah, yeah, yeah.
huh? everybody
Yes,
knows Dr. Subramanian. So
yeah,
in this textbook, he has also given his opinion regarding the Gen point, and he has used the Gen point in his cases of ovarian redo, like you do a complete peritonectomy. This is what your specialty is. And then suppose you have to go back into this patient, everywhere there is loops or bubble or whatever adhesion. So at that time, so roughly I will just tell you, keep from the T12 right up to the pelvic bridge. God has created a nascent zone, and we were just the first ones to recognize it. And in this area, there are never any adhesions, or if at all there are few omental adhesions, like in cases of Cox, where there are complete adhesions everywhere. So if we go at the level of umbilicus, at the upper limit, and about 10 to 13 centimeter depending upon the patient's body habitus. And with the very needle, we go absolutely, can my hand, yeah, absolutely straight and without lifting the abdomen. So this works very well for obese patients, flabby abdomen. You must have seen that when two people are lifting the abdomen, it causes an unequal pressure. So we just simply go straight and keep going through the external oblique aponeurosis, then fused aponeurosis of transversalis abdominis and internal oblique, and then we enter the peritoneal cavity. And this is entered with a 5 mm scope. And then we do a 360-degree check all around. And all of us are able to find some spot from where we can enter with the 10 mm scope. So,
yeah, true. Yeah, this is, in fact, I mean, I did train with Dr. T.S. Rao for, I was there for 2 months. I did a small fellowship with him. So the thing is, sir, I mean, sir knows me very well as well. They, in their institution, they do, as a protocol for all, they do an epigastric port. So yeah, so that is what they do. And as you said, there are such areas that we need to see anatomically, which give us. Of course, for me, I do in a different way because currently ovarian cancer surgery, minimal invasive is still investigational.
doubtful, yeah.
Yeah, so
And in
so
the
because of which we
emerging,
do open.
trying to
Uh,
establish itself.
just yeah,
Yeah.
sorry, ma'am, to interrupt your discussion. I think there you have put a photo in your volume one, third edition. This thing about that giant point, is it?
Do you have?
That port entry point.
Leave
I
you.
know that your Jane point, ma'am, but here that what you are displayed in your right now in front of your that
Oh, yeah.
third edition. Yeah, I think here
Yes. This,
if you zoom it, we can make out.
थोड़ा zoom हो सकता है? Can you zoom it a little bit? She says कि this one is showing the entry with the gen point here.
No, that the same this thing also. And one more thing, I think Rajesh Palladi madam also want to tell. Yeah,
Yeah.
here is it this
Yeah.
one?
Yeah.
Yeah.
Yes, we
So
can see
I
it.
think it was a
So-
very futuristic presentation,
Yes.
Dr. Nutan,
And,
and we found it very
yes.
interesting to listen to the scientific fiction kind of presentation. And in fact, definitely it helps the patient safety and makes it very, safe for the patient whenever we are dealing with such challenges. Especially, I loved your last slide of thank you. It took me to the Northern Lights and displayed such nice depiction. Yeah, I would like to know from Dr. Rupesh and Dr. Prabha, what are the centers in Karnataka, providing this kind of facility, or is it only for the robotic setup?
No,
Or
ma'am.
Mm,
Madam, it is available not only robotic, it is on 3D
yeah,
also. And what Madam was mentioning about these things, they are stores. Stores have these 3D with ICG compatible also, and strikers have their ICG compatibility without 3D also.
okay.
So the
Yeah,
best
striker
without
is
3D
4K.
is having striker 4K.
Mm.
And if you want to, suppose if you are upgrading to 3D, then better to take 3D with ICG compatible like Rubina 4K of stores.
Correct.
Yes,
So,
ma'am. But
Yeah, and
in robotics, it is like inbuilt, but that's too much
Yeah,
investment,
4K 3D. Yeah.
investment for getting ICG.
And,
These two are okay, ma'am.
and for us, it's kind of a de-learning.
Yeah,
Yeah.
yeah.
Laparoscopy now to us is, just while even dreaming, we can do the surgery. So
It's a
what we
really
actually
I
learn.
great
agree with
thing.
that, madam. So the thing is, currently Olympus, Striker, and Karl Stoss, three have
Escalate.
I'm having
ICG.
Escalate
ICGs.
also.
Yeah, Esculap,
Yeah,
and even there is
Esculap
Irilic.
happens.
There's even Irilic also, which is an Indian. I mean, it used to be Indian, but now it's taken over by a UK. So all of these have ICG enabled. But as Dr. Nutan madam said in her initial things, if you saw, there are different modes. There is a overlay mode, there is white gray mode, there is CSF mode, and there's one more mode. So this is all there in 1788, wherein based on the intensity of the fluorescence emitted, the color spectral fluorescence will show very differential coloring, which tells us which is the most hottest node
Hot.
types. So
Yeah.
that only they have. In fact, Rubina and most of the others have the general overlay mode, wherein we get to know dark green, milder green, moderate green, things like that. So in such scenarios, what happens? Of course, we will be looking at the sentinel nodes, but we tend to we tend to remove more nodes comparatively to that when you have the CSF mode. So this is what is my observation. But
Yes.
yeah, and robotics, all of them have the overlay mode type of a thing itself, or even lesser than that. In fact, the Firefly mode is the only thing that they have. So even 1688 also has, I have Manjula Matal madam asking a question. 1688 also has, they do not have the CSF mode, that's all.
They do not have
So,
it. So that
but
is only in the 1780.
yeah, only 1788. But I mean, I would say, especially when you start doing for most of the benign gynecological surgeries, what madam has, enlisted so today, first and foremost is you have to get a hang of doing things rightly. That is, for example, the ureteral catheterization and getting looking at all these things, and the more and more you're used, the more and more your utility and applications will start increasing.
Will improve.
For
Yes.
sentinel lymph node, I always would always put a word of caution. Yes, you may be doing ICG guided surgeries, but very important primarily is the biology of the disease, which we have to study in endometrial cancer. So always involve GYN oncologist, and yes, of course, you may be a better surgeon than the GYN oncologist if in case they are not that trained sometimes. So if that is the case, you need to know, the nuances in, especially in malignancy, because for example, recently there was another case wherein the tumor was more on the upper corpus and more towards the cornu. So I knew that here the paraortic lymph nodes can be the SLNs. So I went up to almost the renal hilum, and when I saw there was one node which was lighting up there, which would have been otherwise missed, So such things, such nuances we should know, especially when we are doing SLN, sentinel lymph node detection for endometrial cancer. But for various benign surgeries, I think any of these good instruments, are wonderful investments. But currently, I would say 1788 is the best investment compared to a robo, which costs about 16 crores. Instead of that, Da Vinci, we can invest in something like 60 lakhs for Striker 1788. This is what my take is.
Correct.
Madam,
And
one question
what
for,
about
sorry,
yeah, what
sorry,
about
ma'am.
the indications of applications other than malignancy for this particular modality?
And that's what Madam showed, no, Madam. Now the entire talk was about that.
Yeah, yeah.
Madam has enlisted so beautifully about
Yeah,
vaginal
including ovarian torsion,
reconstruction,
everything. Yeah.
yeah, endometriosis mainly,
Yes.
ovarian detortion, and even fibroid surgery sometimes, and adenomyoma excisions, especially type 3 fibroids, type
Yes.
2 fibroids also laparoscopically when we are doing. We are not going to enter the endometrial cavity,
Any
and even
complex
vaginal.
benign surgery,
Yes.
you will be better off. Like if you have a huge cervical fibroid and your ureter is illuminating green luminescence. So whenever we are doing broad ligament or cervical fibroid or TLH or a myomectomy, ureter is at parallel. So
Yeah.
again an indication to have ICG in the
Any
ureter.
particular precautionary things or contraindications
Yeah, that's what I
specifically?
said. That only
Iodine,
if
sir.
the patient is sensitive to iodine, if she has iodine allergy, then that patient
Okay.
is known
Okay.
for it. But I've never come across any patient And the only thing is that before starting doing it yourself, like I trained myself into urology way back in only in the 90s, because I thought, because I was trained primarily in the US, and they used to do a cystoscopy even after even every simple TLH. So I picked up that thing from there. Then I excelled into pelvic floor repair, which could also not be done without cystoscopy. So I was continuously, first my teacher is Dr. Arun Tiwari from Agra, and then wherever I get the opportunity, because I was with Selfie and Amasi, and there used to be conferences where the urologists, surgeons, and gynecologists used to be together in the theaters. So that gave us a good opportunity to learn from them. So,
Yes, ma'am.
so
Thank you. Thank you
Very
so
true,
much.
madam. And one more advantage of this, I feel that initially that fluorescent guided catheters and all, the pliability of the ureter used to go off. Here, that the thing is not there. You
not
know,
there.
it guides also, and it will give you the pleasure of moving that ureter freely from means while you are dissecting.
Perfect.
So
Perfect.
that's one. And second thing, just I want to, as Nutan madam is doing one study about the endometriosis and cell phone use, madam has said. So whether, madam, do you feel that using a vaginal cup,
Yeah.
vaginal cup or traditional pads, well, whether that will increase any chances of endometriosis because of that negative pressure what we create in the this thing, and lot much of we don't know, but whether there will be any backflow is more with
Interesting.
that,
Interesting.
yeah, vaginal cup. That's why in your question is, can you please add that also? If no, how many percentage
I
of
will tell you one thing very interesting.
yeah,
That in 1998, I went to Dr. Jacques Donez. Everybody
yeah,
knows Donez's sandwich.
yeah, I know. Yeah,
Huh?
lot much of his studies
Not
we
much
read
of his work
always.
is on
Yeah,
that. So
yeah,
at that time in Belgium, they were working on tampons. Like
yeah.
the dioxin, which was used for the extra whitening of the tampons. And
Mm-hmm.
that was causing endometriosis according to them, the rectovaginal nodules. But
Mm.
what disease I have seen over there in 1998, or even I have seen in my country in 2008 or 2010,
10.
or
Yeah.
even I would say in 20, before the COVID or 22. Now suddenly after with the advent of 5G, I see a you see, many of these surgeries were first surgeries. And that
Yeah.
can totally, carrying the uterus, carrying it like,
Cluster.
yeah, uh, what, a pitu bag.
Yeah, really.
Connected over, tied up to the back. So that brought me to my mind that we should start a good survey. We have at least 20 questionnaires. Let us finish our first 100 cases questionnaire. And if we find something substantial, then we would like to involve some more centers all over India to come to a consensus.
Because yeah, as you something has to means that cause, and so many, as you said, dioxin and DAC, these all plastic uses and those all things are, of course, estrogen related things are increased, that is there. But whether this thing also is a one of the cause, I was just saying that because
Rajni
we're
madam,
yeah,
I'll tell you one thing. Like
yeah,
we did this relay in 2017 to Washington, D.C. Okay. And uh, in that slot, one surgeon was from France and I was from India. And
okay,
I am from a small city. To be flawless relay, we took 100 Mbps. Okay.
okay,
100 megabyte per second, Mbps. That is the, how you interpret. And the relay from France was not as good. But when the moderators from the US asked him that your relay is not coming as good as Dr. Jain's, he said we are not allowed more than 30 Mbps.
oh.
And in India, I was freely using 100 Mbps. And now when I got into starting this survey, do you know 5G gives you 150 Mbps minimum. How much?
Mm.
150.
150. Oh my God.
150. Three times of what was allowed in France. Even we have seen in Dubai conferences, the relay of the live surgery is very poor. You see
Mm-hmm.
that there's a specific word. The screen is all jammed up with multiple colors because the regulation of TRI is better over there. in India.
Mhm.
Okay? We are at a will, Idea will use 150, Geo will come up with 170, and we are happy with the speed. And that is
Correct.
of course what is killing us in, Dr. Rupesh, we will have another webinar on this. Prabha, whenever I'm ready, we'll
Sure,
have
ma'am.
again.
Yeah,
Thank you so
definitely,
much,
madam.
madam. This was, I think, one of the very, very important points because we are just silently, we are
Accepting.
all being busy in becoming evolved or whatever a developed kind of
Ah,
society. But what parallelly we are, suffering or how it is affecting, even the same with malignancies, I would say,
same
the
with
same with
malignancy, yeah.
malignancies. I
We are at
see
a lower
village
spectrum.
people, yeah, rural people who take such good air, good water, and living in
Ah,
such less stress. Even I see so much of malignancies in them, and I
malignancy,
think
yes.
it's all related to the probably. I mean, I'm sure there's a relation to the network or
Mobile.
whatever it is.
And
Yeah,
I think there's one more thing. The poor people are having the dish antennas in their houses to earn some 5-10,000 rupees a month. So that antenna at the household is giving them a lot of irradiation compared to what only a single mobile phone. But these people are watching movies, which gives you easily 2 to 3 hours of and holding it in the hand. Rather than seeing on TV, they are watching on the mobile phone. So it's a good food for thought for all of us, and we
absolutely.
feel happy.
Mm.
After the
Sure.
first survey,
Yeah, correct.
we'll
We are
invite
Definitely, madam. We
surrounded
three
by
of
will.
the
you. Yeah, all
We
the
will be eagerly waiting for your the result, and we will also like to join the hands if you really
sure.
guide us, ma'am. Yeah, thank you, ma'am. And any questions? I'm not finding any more questions here,
One
actually.
question I had, madam,
Yes,
Yeah,
ma'am.
you said visualization of hypogastric nerve by
yeah,
giving
Yeah.
ICG. So that is something which I was a little keen to see.
very
I mean,
yes.
you give
So,
IV and like how is
so
that?
what I said, you people think that I am here to share knowledge. I am here to learn. So, and this is also new for me, and it has to be given intravenous.
Okay.
So
Okay.
So,
we
but how
tried
does the
doing a
nerve
case
see?
yesterday, but she did not come out to be that extensive endometriosis. So I did not feel like doing that extensive retroperitoneal dissection. So that's what I'm saying, Prabha. We'll join again to learn from each
Yes,
other.
ma'am.
And by that time,
Sure.
I have done my lot of maybe 100 cases of hypogastric nerve because we do
Okay.
endometriosis practically just every day. So it will be within no time we'll come up with how we see it
Thank you.
and what dosage we are using.
Yeah.
Madam, for as you said that rectal probe and vaginal these manipulators cups you are, how much means prior you just dip into that solution and then you put into that, or you will
However, it's
inject
very
it?
easy. You have
Yeah.
already reconstituted that
Yeah.
20, 10 ml and then some more into it. So you
Yeah.
take 5 ml for the ureter. The rest of
Yes,
it
ma'am. That
remaining
is
in the
there.
bowl. Yeah.
Yeah.
You just dip your cup into it
Huh.
and then
Yeah.
apply it. Or
Okay. So
dip
it
the
will
tip
take.
into it and put it inside the uterus. Or
Oh,
you take
okay.
it on a sponge and put it in the vagina.
Okay. Okay.
So,
Hmm. This for that, I think we need to dilute it because it will has to soak, no, ma'am.
no, it
I
is already diluted. If you want to dilute furthermore, then maybe the luminescence will not come.
come. Okay.
Because vagina is
Yes.
also a
But
thick,
but
thick
as
tissue.
you will see that we have reduced our dosage from 2 ml to just 1 ml.
1 ml.
And this is catching a lot of attention from wherever I speak about this.
Any maximum dose limit is there?
No, no.
And can we
1.25
repeat
ml.
it?
Yes,
Repeat
yeah,
some,
that's a
yeah,
very good question. So usually we do not need to repeat. Usually. But yes,
yeah.
if you need to at times because now we are trying to inject as less and less possible because we are a part of the Delphi trial also. And they are also asking questions, how much and after what time did you repeat? So the first dosage we are reducing and very little time. So maybe 1 in 100 time we need to give a second dose. Very
Okay.
soft. very less.
Because most of the surgeons they are using for liver surgeries and for gallbladder any this thing, because it will go and release wherever you give IV, it will go and I think it will take 2 days.
No, no. I'll tell you one thing. For the gallbladder surgery, when they inject IV bolus, because we do a lot of hysterectomies and gallbladders together,
Yeah,
so then everything, the liver, gallbladder, everything becomes green.
green.
So if
Okay.
you want to see only the bile duct, the CBD as green, it has to be given at least few hours before the surgery. So
Okay.
pre-op, the nurse is trained to give IV bolus, and then when the patient comes after 2 to 3 hours in the operating room, then from the liver it would have already metabolized or has been washed
Okay.
out. So then you only see the CBD as green as the ureter we are showing you. So
Okay.
these things are evolving. So
Okay.
this I learned because I go to places where surgeons, oncologists, bariatrics, everybody is speaking about their experience.
Mm-hmm.
So
And till then, the once you inject, you have to finish the surgery within how much hour?
Oh,
For
because
sentinel lymph nodes and
yeah,
all.
our time after the way I showed you, so
Yeah.
plus 2 makes 4. So my surgical time for all these cases has gone down to 1.5 hour only.
Okay.
And
Yeah.
earlier it used to take 3.5 hours. So ICG illumination in the ureter remains the same. Yeah, because
Okay.
there are surgeries like one of the TLHs probably I showed had a big bladder endometriotic nodule also. So
Okay.
2 hours for the TLH and then another 2 hours for the bladder nodule. Oh, sorry, we forgot to put that. It would have been interesting.
And
So
for
Okay,
there
sentinel
was a
ma'am.
lymph
very big
node,
bladder nodule.
yeah,
Yeah.
sentinel lymph node, at least 15 minutes after the injection, we of course immediately look also, because after the
You should
scoping,
look
yeah,
immediately.
look immediately.
That's for
But
the lymphatic channels, I think. You are a
yeah,
better expert for that.
yeah, it
But
takes around 15 minutes time for the lymphatic clearance of the
yes,
dye, whereas
yes.
IV it is immediate. I mean, it is very quickly because it is transmitted. It mixes with the lipoproteins in the blood, and immediately it is there everywhere. But in the extravascular areas, interstitial areas, it takes time for clearance. As it comes through lymphatics, it takes around 15. So, no, I mean, by that time, within that time, you should be ready. So what I do is, like, I would have used sharp dissection, non-energy dissection to open the retroperitoneum, and just like blunt dissection, I would have just made till the obturator areas, because many a time obturator is the SLN. So once you have the vision ready, and then you go inject and then come back and have a look before 15 minutes. Once you are just having a look, you will see which is the first one. So that's how it is.
That you do.
Thank you, ma'am.
Yes.
I think we are in time with lot much of discussion and with lot much of we have studied well this thing, and I'm so happy that all the these things participants are from even other state also has taken active participation, but majority of them are cleared with the concepts and a lot much of discussion. I think this kind of webinars help them much in learning, rather than just we are giving a talk and going on and saying that there is no time for the question answers or the discussions. So
Correct.
when something subject is a new one, I think there should be a lot much of discussion. And thank you, ma'am. Thank you for giving your valuable time for us. And we will look forward for your any new inventions and interventions you always go on doing. So we'll look for that. Thank you, Rupesh sir, for giving your in busy schedule. Also, you have given me time for our
Anytime,
association. Thank you,
anytime
Rajeshri
for you,
Palladi
madam,
madam,
for
for
Rajshri madam.
till the end. Rajeshri madam is there,
Very
and
interesting.
I really appreciate her enthusiasm to learn the things from
I know.
infertility to laparoscopy and everywhere. And in spite of
We
so
can
much of
achieve.
in her head, for now, tomorrow is a ICOG conference in Bangalore, and the even state conference is going on there in that preparation at Gulbarga. Madam, today we have received a personal invitation by Bhageshri. Madam has come today, and she has invited us in Gadag. Thank you, ma'am, for sending your all representatives all over the Karnataka and so. And thank you everyone who has attended and given a time for this valuable
Thank you.
webinar. Thank you,
Wonderful
ma'am.
learning.
Thank you.
Thank you.
Thank you.
Yes,
Bye-bye
ma'am.
from
Thank
me,
you.
and it was really very nice listening to Dr. Rupesh, Dr. Prabha, and Rajshri Madam.
Thank you. Thank you. Thank you.
Definitely, I would like to share that questionnaire on endometriosis, and
We
let
would
us
love to.
start the momentum. Maybe
Yes.
Sure, ma'am.
more people will join.